today we are in Dubrovnik in Croatia. Today is 13th of 2017. Together with me is Professor Blayney from United States, a famous American oncologist. And thank you so much for that you agreed to talk with us and to interview for this ITV channel.
Yes,
Thank you, Douglas. So may I ask one question first of all? Could you just describe your way in medicine? So your previous experience, and that's interesting. That's very interesting for us.
I became an oncologist because 40 years ago, I could see there would be great progress during my professional career, and that certainly happened. I started out treating patients with chemotherapy. Now we're using targeted treatments, and it's very exciting. We have many more treatment options with patients, and furthermore, I think I work with surgeons, with radiation oncologists, and with pathologists, and we have a team.
Multidisciplinary.
And we're multidisciplinary, and that is great satisfaction to me, and we can do good things for patients as well.
Yeah.
It's been fun.
Thank you. I just want to say for our spectators that Professor have a 45 Hirsch index in the Google School. That's really that's famous result, you know. And I just see many of your manuscripts in articles in New England Journal of Medicine, in Lancet, in Journal of Clinical Oncology. And you know, I just paid attention for some of your manuscripts where you just implemented the definition financial toxicity. You know, that's interesting, you know, financial toxicity. Could you please tell us shortly what you mean, and that's interesting.
Well, thank you. I didn't invent that term, but it's certainly a very meaningful term. So in our country and many places around the world, the new drugs are very expensive. We don't have a way, often, even though we have insurance, patients have to pay co-payments or pay out of pocket for some of these drugs. Very expensive. They often don't tell us, gee, doctor, I couldn't afford my medicine, so I'm only taking a half dose, or I just haven't started it yet because I can't afford it. So that's as much of a toxicity as the nausea and vomiting and neutropenia and other things we typically think of with chemotherapy.
Yes, so that's interesting. At one of your GCO, Journal Clinical Oncology publication, you just described the recommendation for the countries with low and medium incomes, because as you see, this program is actual for United States, but we have a lot of countries with low incomes. So what is this way you just predict for the countries with low incomes, how to treat cancer when we are limited with resources? You know?
Well, it depends. But I think breast cancer is a great example. In countries where women present with large masses or large fungating masses, mammogram screening is not important. It's the major event is getting women through the operations, through training surgeons and their teams to be able to get women through the operation. That's as important as anything. And then when women present with tumors that are smaller, when the health system evolves and resources available, that's when we worry about picking up smaller tumors. That's an example of this.
So once again, in your manuscripts, I paid attention that you for a long time tested the T cells and T cells activations process in some publication about T cells and immunity and so on. Just now, what do you think about this predicted breakthrough of modern immunotherapy? What is your relation for this process?
Well, I've had patients all along saying, doctor, can't my immune system help me fight this cancer? I think finally we're beginning to understand that maybe it's a very special part of the immune system we can activate or turn on to help fight the cancer. The problem that many people don't understand is that when the immune system fights the cancer, it also can damage the normal tissues, particularly the lungs, GI tract, thyroid, places we hadn't even thought of. So we need to it's just not a magic bullet to the immune system. We need to understand how to treat those toxicities as well.
It means that we receive the new weapon, but we must handle this very carefully.
But it has off-target effects.
Yes. So as I understand, do you believe that it may be tested in the mode of clinical trials this way to find the correct answer for this question?
Yes.
What is the attitude and relation for clinical trials in general in the United States? Are the people willing to participate or faced with obstacles?
Well, for as long as I've been practicing, we've been able only to put about 3 to 5% of patients on clinical studies in our country, in the United States. And then from those 3%, we have to generalize to say, well, how do we treat the other 97% of patients? So we have to get, first of all, more patients involved in clinical trials. I think we have to make it easier to be for both investigators and patients to be in clinical trials. And then we have to learn from every patient. And some of these big data approaches that we're using, including CancerLink, which is a big data, amalgamating a lot of data from electronic medical records, is a way to learn from every patient.
And maybe the last question, so this is the problem which we just discussing here today. You know that we're just talking about expensive chemotherapy, expensive cancer systemic treatment. So another question that we have a need for really reliable support and preventive activity to prevent complication of chemotherapy as well as just now for immunotherapy and so on. That's why, do you believe that it is really possible to change the strategy, let's say, and transfer our activity, let's say, from to defend neutrophils? So do you believe that defending of neutrophils from the damage from chemotherapy, it is really possible and may be realized, this idea?
Yes. We've shown that in breast cancer with you can use dose-dense adjuvant treatment in breast cancer. You get better results for patients. Other cancers, not so much. So this new trial we're discussing today will hopefully be helpful.
Okay, so I know that you are one of the world leaders in this direction, in this research, and I want to wish to you and to all of us success in this very necessary activity. And thank you once again for your for your decision to give this interview. Thank you, Doc. Thank you so much. Thank you. Today we are in Dubrovnik, in Croatia, once again, and our famous professor today was talking with us. Thank you so much. Thank you. Seaside TV channel, Seaside TV. Thank you.